Oh, I hope you feel better by tomorrow. No.
All right, a very good evening, everyone. Can, am I being heard?
Yeah.
Excellent. Right. I want to say a special good evening to the persons I know, Alan, Margaret. I see Everton, one of my heroes. I just want y'all to know that as a nurse, most of my heroes are sitting on dialysis chairs 3 times a week, doing 3 hours, sometimes 3.5, 4 hours. I'm inspired and encouraged by many of the patients I care for. I call them valiant warriors with reference to the way in which, the attitude in which they approach the condition in which they deal with. So that in essence motivates me with reference to how I approach my, my vocation as a nurse in hemodialysis at this time. Just a little background, I am a nurse trained in renal replacement therapy, also specializing in operating room technique. I also specialize in emergency room. So I come with that experience in a dialysis setting. And as I said, I've learned a lot. I've learned a lot over the years. And I learned most of it, if not all, from my patients. So I want to say thanks again. And on that note, I want to let you know today I'm just going to be touching, as Alan said, we're just going to be touching on some topics, and we know it's going to stimulate discussion. For caring for someone with end-stage kidney disease, we're going to look at the importance of dialysis, types of dialysis, fistula and catheter care, and managing your liquid or fluid intake. So why dialysis? And we know that we have 2 valuable organs, and some of us will have had them functioning to full capacity. And it is when those organs stop doing what they're supposed to do that we need some help. We need support. We need to have some type of support that will replace what those organs will have done. And I must say that approximately 1.5 liters of blood are filtered by a healthy person's kidney each day. And we could not live if these waste products were not removed from our kidneys. So when you hear people say that dialysis is life-saving, it is life-saving. And people whose kidneys either do not work properly or not at all experience a buildup of waste in their blood. And without dialysis, the amount of waste products in the blood will increase and eventually reach levels that will cause coma and ultimately death. I just outlined the 5 stages of chronic kidney disease, and to just remind us, the objective or determination for placing a patient on dialysis will be when they're at stage 4, when you're getting less than 15 mils per minute over 1.73 meters squared. That is kidney failure and stage renal disease. So basically what it's saying is that your kidney just ain't filtering. It ain't doing what it's supposed to do, right? And so dialysis steps in to do those 2 major things that the kidney should have been doing, which is ultrafiltration, and which is creating your urine, and also getting rid of the toxins. Now, just to remind us of the anatomy of the kidneys, we have 1 kidney on the right, 1 kidney on the left, just below our ribcage, and they are supplied by the inferior vena cava, large blood vessels, and the aorta. And we have the renal artery and the renal veins supplying them, and we have ureters coming from the kidneys going to the urinary bladder, and that follows on with the urethra, which we pass our urine through out to the external environment. So just a brief overview of the anatomy. Hemodialysis, what is it? As we mentioned, it is a process, and to actually commence and maintain this process, we must have access to the blood. So hemodialysis, we need to have an access created, and this access, maybe a fistula, a graft, or a central venous catheter, allows for us to remove blood, and the blood circulates through some plastic tubing called an extracorporeal circuit, and this goes by way of a dialysis pump to a dialyzer, where the scientific principle of diffusion takes place, where exchange of molecules occur, where ultrafiltration also occurs, and the waste goes down the drain. And after that, the blood is returned via the blue line, which will be your venous needle or the venous side of your central venous catheter. Caring for someone with end-stage kidney disease. The important thing I have realized is that we must work with our clients, our patients. I'm in the private sector and I tend to gravitate towards clients. Patients tend to be a word that I tend to associate with a lot of dependency. I'd like to see the independence where our clients are involved. They come and they say to me what is happening, what they want to do. And I'm glad Everton is there at present. Everton is one patient who knows himself really well. He knows what should be happening at any particular time. And so I want to emphasize that we clinicians must work with our patients, our clients, to help them and us understand their kidney problems. We must help our clients to filter information, especially in these times when so much information is available and so much wrong information. And the wrong information is so available and comes so frequently that we as clinicians now have to take the leadership role and guide our patients to good scientific facts. We must support our patients to make informed decisions about their future care. And this care could include dialysis or not having dialysis, kidney transplant or not having kidney transplant. And there are clients who will have been given a poor prognosis and want to still continue with conservative palliative care. We must support them with that also. And the nurse should monitor, or the clinician monitor, kidney function and inform the client of improvements and changes, and in a timely fashion that the client can make informed decisions and changes to their regime. Peritoneal dialysis now is another form of dialysis all of us are aware of. And although this is one that we will prefer most patients to take as a first option, we know everyone comes to hemodialysis. And but this is really indicated for patients who have refractory heart failure, who have vascular issues, meaning you can't find no vein to create no fistula or no graft, and sometimes patients have to have dialysis done. This is also done for pediatrics and things like that. We have CAPD, IPD, CCPD, right? Chronic ambulatory peritoneal dialysis, intermittent peritoneal dialysis. And we have automated peritoneal dialysis now, which we can have our clients go home with a cycler and they can be connected and have their dialysis during the night. The thing with peritoneal dialysis, where we have to have the tube, a catheter surgically placed in the peritoneal cavity, and we allow fluid to dwell, and we then dialysis occurs in the peritoneal cavity. Persons can do this while they're asleep. They can do this while they're in the day at work, and it gives them more autonomy and more independence. So peritoneal dialysis is still an option, and it has proven effective for more people, especially now that automation has stepped in. Now, caring for someone on peritoneal dialysis, the peritoneal nurse should provide education, a lot of education as it relates to helping the client to be able to manage themselves at home, helping them to create a safe and clean environment, teaching them aseptic technique, good hand washing, and teaching the relatives and the family how to take care of themselves, how to identify when there's an infectious situation going on that will put the person on peritoneal dialysis at risk. And we know that the major complication is peritonitis, and that happens because that bacteria that behaves so well on the outside of the skin can get into that exit site and cause problems. That bacteria called Staphylococcus aureus. When we're looking at hemodialysis and fistula care, now we have the AV fistula is the gold standard as it relates to access. And this is an artery and a vein joined together by way of anastomosis to create a larger vessel, which is called a fistula. And three that I have demonstrated here would be the radiocephalic fistula, the brachiocephalic fistula, and the brachiobasilic fistula vein transposition. And the names only reflects the blood vessels that are used. So we use a cephalic vein and a radial artery for that first one, and that's sometimes called a snuff box. And we use a brachial artery again with a cephalic vein for the second one, right? And then we use a basilic vein with a brachial artery for the third one. And these accesses we call the lifeline, and these should be managed in a particular way and should be cared for. We encourage patients again not to lift heavy objects using the arm, not to tourniquet their arm, not to take blood from their arm, blood pressures from their arm. If they identify any problems, they should report it as quickly as possible. And we encourage us ourselves as clinicians to rotate our stick sites. Although patients become comfortable in being stuck in one area because the nanoreceptors are gone now, so they're not feeling, we should still protect our patients from pseudoaneurysms by rotating our needles. And it's just to show you how now a graft, how it is joined in a similar fashion, joined to an artery and a vein. And that is an artificial device, synthetic piece of device that is used when a person has problems with their veins, they're too small and they need something to give them an access. A graft can also be inserted, right? And this is just to show you a nice brachiocephalic fistula and how it looks, and talking about best practices, putting your needles at least 3 millimeters apart every time I'm rotating, and sticking to what we call a rope ladder technique with regards to cannulation. Arteriovenous graft, and we look at the graft, sticking the graft in the wrong place can be a problem, and we must know where our arterial end is and where our venous end is located. And that's why we must encourage our surgeons to send a mapping back to us with instructions as it relates to where to cannulate. Now, again, as you can see, what I explained just now, where the arterial needle goes to take blood away in the graft and where the venous needle returns the blood. For fistulas and graft, as I mentioned, don't do these things. No needles, don't wear tight things, avoid sleeping on your arm, or it can lead to problems. Wash your hands with antibacterial soap each day, always before dialysis. Do not scratch skin or pick scab. Check for redness, feeling of excess warmth, or the beginning of a pimple, or any area of your access. On any area of access, leave that alone. Ask your dialysis care team to rotate your needles. And then we have the central venous catheters, and this is another form of access. And you can see where this catheter, which is a foreign body, and we really would prefer not, but again, because of vascular issues, also because persons may start dialysis in an emergency fashion and not had the chance to have an access created, then a catheter may be used, but also catheters are used long term. And you can see where the catheter enters by way of the subclavian of the external jugular, the internal jugular. The external is normally used for temporary and the internal permanent, along with the subclavian vein. So those are just the vessels that are used, but this catheter goes right into the superior vena cava and dumps into the right atrium. Catheters, again, care of the catheter is very important, and we encourage persons not to allow them to become soiled, wet. Don't go into the shower and get them wet. Don't go into the beach. When the dressing is soiled, should be changed, but we do change those ones on the chest, alternate days, and the femoral catheters, we do them every day. And our antiseptic we use here is chlorhexidine, which is the gold standard as it relates to an antiseptic, which destroys more than 80% of the Staphylococcus aureus, which resides on the skin. We try on initiation of dialysis, we still remove our lot that is inside, maybe heparin, trisodium citrate. That is removed, we flush, and that flush is an assessment to determine how we're going to connect. Although ideally we should connect red to red, blue to blue, sometimes one may pull a lot easier than the other, and we can transpose or reverse the lines. And And this is just an example of a femoral and some guidelines. Again, gently peel off the old outer dressing. This is what we clinicians do, and throw away the old dressing with our gloves, put on new pair of gloves, and we reapply a dressing for our central venous catheters. For peritoneal catheters, wash our hands, use alcohol, hand gel, wear clean gloves, remove dressing. And this is for patients also. Check exit site for redness, swelling, drainage, or soreness, right? And we get to the Achilles heel of the dialysis patient, fluid. Fluid is the problem, always the problem. We know, as Everton will have mentioned, 1 liter in 24 hours is what we will have encouraged our patients to do, but people do have challenges. We heard one client ask just now where it is that she's so thirsty, and Everton really explained about the sodium content of the dialysate. But it is still important that we try to be strict in regards to our fluid management. But this slide shows how it can affect the different system, the neurologic system, changes in your loss of consciousness, changes in your consciousness, confusion, headaches, seizures. It can affect the cardiovascular system. It could affect your gastrointestinal symptom and your respiratory symptom. And ultimately, you can see the edema, the dependent pitting edema that you will see in your ankles because of your fluid overload. Now, what can you do? How can you avoid fluid overload? Track your fluid. Some patients use a visual to help them see how much fluid they're taking. I know one of my patients, he uses scale. He steps on his scale and determines where he is. And that determines how he's going to go in with fluid and with food. You know, find a container that you can make, that you can mark or keep a journal of every liquid you have on a dialysis on a daily basis. Follow your liquid guidelines. Manage your thirst, right? Your dietitian, nutritionist can help you with this, ways to manage your thirst, such as sugar-free hard candies, ice chips, or frozen grapes. I know to talk about lime, frozen lime blocks also. Manage your sodium intake, pay attention to your labeling, watch the pigtails and all the processed foods. And sometimes we can adjust your dialysate. If you're coming heavy, we can adjust your dialysate, or sometimes if you haven't put on weight, we can adjust your dialysate to give you a longer time if you have not achieved that as yet. So in summary, dialysis is important because it replaces 2 important functions of the kidneys. And there are 2 types of dialysis, renal dialysis, which is hemodialysis, and peritoneal dialysis. Dialysis access is the patient's lifeline and should be cared for with the highest standards and asepsis. Managing fluid intake is important in maintaining good health when on dialysis. Thank you.
Thank you as well.
Thank you. Thank you so
Thank
much,
you.
Mr.
You're welcome.
Does anyone have any questions for Mr. Herbel? His slides and everything were very informative and well explained, but I don't know if it prompted any questions from us. I was making notes, so yeah, he had me researching.
The question about the catheters not being wet. Sometimes we go to bed at night and in the height of our sleep, we are wet. When we get up, the catheters are wet also. What can be done to avoid this wetness?
Yeah, hi Anela, how are you doing?
I'm fine.
All right. Yeah, you can change your dressing, and it is encouraged for you to have some emergency supplies at home. You should have some gauze and you should have some tape or Hypafix at home, and you can change even if you change the outer dressing. You know, you should actually not allow that, depending on how wet it is. You should make yourself comfortable, but you can change your external dressings. Because I know the technique that is used, there is an internal dressing and there is an external dressing. So I believe that you can change your external.
All right, thank you.
You're welcome.
All right, well, I think that we don't have any other questions right now. So we're just going to move on to.
Tanisha, just I want to say that.
Go
I just
ahead.
want to ask this is a non-medical question.
to nurse. Normally, nurses deal with patients for a couple of weeks and they never see them again. Dialysis is special, where you deal with a patient sometimes 10, 20, something 30 years. How can a nurse maintain that care, but at the same time, because of our problems and the period which we have to deal with us, that you don't get too involved with the person emotionally? How do you balance that?
How you balance it? Well, as you said, dialysis is special, and we nurses do develop emotional connections with our patients. We do grieve too when we lose patients. We do go through our emotional roller coaster because, again, we are human beings still. We carry out a role and a function. Some of us who are called to a vocation, carry that out, but it is a challenging thing to do. What we still need to do, although we can get that emotionally involved, we still need to draw the line and to set boundaries with reference to how we communicate, because you still want to have the professional nurse-client relationship existing, or else both you and the client will not be of any help to each other, and it will be defeating the purpose. So it is a balance that you have to, it's something you have to juggle, and is a balance. I know that, again, as you said, because of the peculiar situation, and nature of the care is one of the challenges, and that is a very good question, Alan.
Hi, good afternoon, everybody. Adding to Nurse Hurdle's input, my name is Abiola Batiste. I'm a registered nurse, dialysis nurse at the John Hayes Memorial Kidney Foundation out of Trinidad and Tobago. And added to Nurse Hurdle's input, what I would also say too is that we nurses also abide by our own internal code of ethics. So while I would have, a lot of patients have my number, because from time to time, sometimes things may be happening, whether it's an emergency, something is happening at home, they may not be able to access the clinic's number. The clinic might be closed, something is happening, and they may feel they need to call me to say, okay, Nurse Batiste, this is happening, and I could tell them, well, all right, go to A&E or, whatever. But at the same time, I always try to keep it professional. So depending on the nature and the topic, what is, is being asked or what is being said, I give professional advice, and anything more than that, depending on the situation, I may have to put them on to the nephrologist or whatever, but at the end of the day, you abide to your own ethics, the nursing ethics, and your personal ethics too. You understand? You know what is professional from what is not, and you keep it as much as possible along that line while trying to give help.
Yeah, thank you, Nurse Baptiste. I endorse that. And Alan, we abide by a code, the International Council for Nursing. We have a code of ethics in regards to how we should function, how we should behave. I think we are governed also by a Caribbean Regional Nursing Association, and and our General Nursing Council, right? And also our policies and procedures of our facility that we work at, and we got to know how far we can go and should go without violating those boundaries.
Another thing, sometimes most patients, the only happiness, I would say, and the only time you feel like appreciated and all of that is when we go to dialysis. That's because when we go to dialysis, we see it as a family. We look up to our nurse as our mother and father, and we look at the other patients as brothers and sisters. The thing is, some patients, they are living alone, and the only time their comfort is when they get to dialysis. So what I think should happen is our nurse should try to dive into our lives, find out, are you okay? How are you doing? What's going on at home? Are you comfortable, etc.? But patient to patient, I think we handle it pretty well because we are always there for one another. Although some patients think they're more than others, and some patients even think that in their state, they shouldn't even be among us. So Ian,
Yeah. Yes, I know, I know what you're saying, and we do have those special cases, and we have social services also, and we should refer those persons because you all must remember that many times the nurse too can be distracted from doing the other thing that is also important. I'm not saying what that need the patient has is not important, but we got to be able to know where we need to step off and where we need to refer and allow the patient or the client to receive care that we may not have the time or it may not be expedient for us to give. So we have to know when to refer.
thank you.
You're welcome.
Alana raised some very interesting points there. And Alana, what we want to do as part of our group is that we want to develop something, a forum that our patients can also communicate with one another and assist one another. So that's saying that we can look to try to develop it. We can't explore it right now, but we can look to explore how that can be done. And I will be communicating with you some more as to how we can get that done going forward. Back to you, Tanisha.
All right, back over to me. And now let me just check here. I think we have Sadie up next, Sadie Ann Cisnet. And I think I pronounced that correctly. And she's a transplant patient from Barbados. So we are going to hear from her shortly. Well, I am not seeing her, but I believe she's here. She's here, right, Alan? Not seeing her.
Yes, I'm here. Can you hear me?
Oh,
Yes,
yeah.
we can hear you. Okay, hi, Sadie. Yeah, so we're
You
gonna
see me?
hear.
My video's okay?
Yes, please. We can see you well. All right, so we're gonna hear from Sadie Ann. It's not no, and she's gonna have a short conversation with us. So go ahead, Sadie.